As we know, in breast cancer radiation, it was an area of debate. Those N1 patient, 1 to 3, positive lymph node. So many debate about to give a radiotherapy or not, to what volume. So post-mastectomy radiotherapy for those patients with stage in local regional control. Metastatic spread to lymph node, regional lymph node, axillary lymph node is one of the earliest events of tumor dissemination. And as we know, this opens the gate for more dissemination and for prognosis. National Comprehensive Cancer Report guidelines recommended that supraclavicular irradiation as a necessary treatment for those patients with N2 breast cancer after surgery. However, supraclavicular radiotherapy is strongly considered for patients with N1 breast cancer if post-operative radiotherapy is indicated. So National Institute for Health recommended supraclavicular radiotherapy for N1 patients if they have poor prognostic factors, like advanced T stage, T3, or great stage, and performance status. So we have a debate and controversy regarding the use of supraclavicular radiotherapy for those patients with N1 axillary lymph node from 1 to 3 lymph node affected. And many authors studied the patient with N0 also, those patients with node negative patient and N1 breast cancer, and didn't receive supraclavicular radiotherapy. And supraclavicular node that recurrence rate was ranged from 1 to 8%. The issue of those patients with 1 to 3 positive lymph node should receive post-mastectomy radiotherapy. And if that, what volume remain a controversy among oncologists. So the aim of this work is to evaluate the prognostic factor for supraclavicular relapse in N1 breast cancer patients that may judge the need for supraclavicular radiotherapy. And this is a retrospective study conducted in our department, Clinical Oncology in Tanta University, and included 113 female breast cancer patients treated with even conservative surgery or modified radical mastectomy and axillary evacuation. All patients had pathologically proved breast cancer with T1 to T3 N1 M0 tumors. Mastectomy was performed in about 2/3 of patients, and the axillary lymph node dissection was performed in all patients. Chest radiation, chest wall radiation after chemotherapy is given for patients, all patients who have a conservative breast surgery, and with lymphoblastic invasion, extracapsular extension, and age below 35 years, and those patients, of course, with tumor 5 cm or more T3. In addition to the breast and chest wall was given through 2 tangential field without supraclavicular radiotherapy for 50 grays in 5 weeks, 2 grays daily for 5 days per week. 87 patients received adjuvant chemotherapy. Many protocols was given at this time. Some received CMF and FAC or FEC. All the chemotherapy regimen was administered IV for average 4 to 6 cycles. The patient was positive for hormonal receptor, of course, subjective for hormonal therapy 5 years. Supraclavicular recurrence-free survival and distant metastasis-free survival were evaluated from the date of pathological diagnosis to the date of event or the date of the last follow-up. Overall survival was measured from the date of pathological diagnosis to the date of death or the date of last follow-up. We have in the patient, our patient characteristic, we have many these factors, age as regard to the age, menopausal status, location, pathology, grade, size, the number of removed or the number of retrieved lymph node, positive lymph node, and the percentage, say in another way, the lymph node ratio. Also, we have the extracapsular extension, lymphovascular invasion, and hormonal receptor surgical interference. Patient receive radiotherapy, chemotherapy, hormonal therapy. As we know all of this, patient characteristics, most of them are prognostic and predictive factor for us. In this table, we can see that age, most of our patients in the age from 35 to 60. About near 60% was minipositive. The outer location of the tumor was in about 80% of patients. Infiltrated duct carcinoma was very common, more than 90%, and we have about 2/3 of patients with T2 tumor. The number of removed lymph nodes, more than 10 lymph nodes removed in about 3/4 of patients, and we have patients, about 3/4 of patients have lymph node ratio less than or equal to 20%. Also, we have in our treatment this patient about 90% or near 90%, 89% was hormonal therapy, was hormonal receptor positive lymphovascular invasion noted in only 40% of patients. Extracapsular extension was noted in about 1/4 of patients. This curve shows the 5-year supraclavicular recurrence-free survival in our patient was about 90% of patients. And this is the 5-year distant metastasis-free survival, and was about 80%. And this is the over 5-year over survival, about 88%. And we subjected our prognostic factor to in the univariate study. We have the univariate and it shows this significant prognostic factor to include in the Cox model for having the multivariate analysis of this factor. We have in the univariate, we have the size, the positive lymph node, the percent of positive lymph node, and the extracapsular invasion. Lymphovascular invasion was a prognostic impact on the overall 5-year survival. When we extract this in the Cox model, we have found that size, T-stage, and percentage of lymph node, extracapsular invasion was independent prognostic factor. According to these independent prognostic factors, we have the tumor size and the percent of axillary lymph node and the extracapsular invasion. We make the patient into 2 groups, subgrouping low-risk group and those patients who have 0 to 1 prognostic factor, and the high-risk group, patient with 2 or more risk factor of this independent prognostic factor. And this was a 5-year supraclavicular recurrence-free survival according to this model, to this classification. The low-risk group and the low-risk do much better than the high-risk group and have a very high significant impact as regards the 5-year relapse-free survival and the median relapse-free survival also. And this is the supraclavicular recurrence-free survival between the 2 risk groups. This is also distant metastasis-free survival between the 2 risk groups. And this is the overall survival between the 2 risk groups, and all was highly significant. So distance-free survival according to supraclavicular recurrence, and overall survival according to supraclavicular recurrence. So we can conclude that tumor stage, percent of positive axillary lymph node, and extracapsular invasion were independent prognostic factor for supraclavicular recurrence. So in breast cancer patient with 1 to 3 positive axillary lymph node treated without supraclavicular radiotherapy, we suggest that patient present with 2 or more high-risk factor for this independent prognostic factor will given statistically significant benefit from addition of supraclavicular irradiation to chest wall irradiation as regard supraclavicular relapse-free survival, distant metastasis-free survival, and overall survival. However, of course, further a single study with a large number of patients and many other communities and judgment and other institutes, we need to make larger study to judge our need for supraclavicular radiation. Thank you very much.